My name is Martin Pham. I'm from University of California in San Diego. I try not to brag about it too much, knowing that lightning may strike, but hopefully everyone is enjoying the Spine Tech Summit so far with a lot of the really great presentations that have been going on all day. Now, I will say though, and I'll make a comment. So, our program advisors and chairman have put together a really wonderful program with a lot of discussions and all the innovations being explored today. And I do agree with what Dr. Lehman's presentation said last night on his opening session, that there is a very fine line between being a mentor and a tormentor. And I trained under Dr. Lehman, and seeing him up there just beating up on Dr. Pauly, I look forward to the day where one day, years from now, the situations will be reversed, and I have an opportunity to go up head to head against him. Now for this talk, just a brief introduction, then we're going to go right into the cases, which is really the most illustrative part of this workshop, especially when we're discussing construct design and deformity, and then just a brief conclusion as well. So in terms of the introduction, again, this is an example of a robotic arms in a Tesla factory, right? So you can see that robotics is exceptionally precise, accurate, and reliable, and has been a part of our daily industrial life for decades. And now we actually have an opportunity to bring this type of technology into the operating room, right? So when we talk about robotics, it is essentially just an iteration of a tool that is getting better and better. And so when you think of a screwdriver, right, we start out with a manual screwdriver, and then we get something powered, and then we end up with an automated or semi-automated piece of equipment that can do the same task, except now more accurately, precisely, and reproducibly. Now, when you get into robotics and CNC type machines, it does mean that robotics requires an input, right? So an input is required for there to be an output in the destination or geographic location in three-dimensional space of the target. In this case, the input for the Mazor X is the planning software, right? So putting your idea and design in the software is what allows the robotics platform to take you to your goal. And in this way, planning software simply allows you to execute exactly what you have in mind anyway, right? So it doesn't change how you do surgery, but the idea is that it helps you do that surgery better, especially when we're talking about deformity correction and long segment surgery, where there are so many things to think about. If you remember from Dr. Lehman's slides, he opens up and there are all these things, right? A-lift, T-lift, O-lift, correction, rodding, the patient's comorbidities. There are so many things already to think about, and this should not be one of them. And in this way, the bony fixation, and a lot of you have already heard me tell this analogy already, but I see bony fixation in putting in pedicle screws like pouring the cement or pouring the rebar for a building, right? It's not the surgery itself. It lays the foundation, but the rest of the surgery, the grafts, the osteotomies, the deformity correction, that's where the surgical goal is accomplished to make your patient better. And so if you can reduce the amount of time or the amount of frustration or the amount of troubleshooting that is spent on just putting in the screws, more time can be spent on actually fixing the deformity. And this is where the idea comes in of the design, right? So instead of focusing all of your attention on just putting in cement, right, putting in a pedicle screw like a handyman or a contractor, more time can be spent on being an architect, on actually designing what you want for your patient and their spinal deformity. And in this way, these are the possibilities that are opening up within the software plan. Planning out where you want your screws, where you want your rods, the expected correction, and the expected design. And this is why I term this as being more of the architect in the design of your construct. Now, in this way, this is an example of what the software planning looks like. And down here, for those of you who have seen this button, the X-Align software is part of that predictive algorithm where you can put in your cages and bone cuts to anticipate and predict the types of correction that your patient should get. So going right on into cases. In the cases section, it's split open into two sections. The first part is on open deformity, so something that a lot of people are very familiar with. And for me, demonstrating on how spinal robotics and the software planning can integrate into that practice. But the second portion is on minimally invasive deformity. And Dr. Poulter touched base on this in the general session because now there's the possibility to do deformity corrections minimally invasively because of the power of segmental planning and the power of being able to put in the entire design of the construct. So open deformity first. So this is a very standard case, a T4 to pelvis, someone coming in with a prior Harrington rod, now with sagittal imbalance. So here is the software plan showing all of the placement of those screws. Now, for anyone who's ever operated on a Harrington rod or a revision case, it is not an easy surgery, right? There's prior instrumentation, there's prior fusion mass. All of the landmarks, especially with the scar and soft tissue, can be exceptionally confusing. But I will tell you that for this case, which you can see a bird's eye view of just what just looks like a mess, putting in the screws was the least difficult part. And you can see here, good apposition of the plan from L3 down to S2, from T10 down to L3, and from T4 all the way down to T9. And so what this means is that the entirety of the surgery I could spend on doing the osteotomies, on doing the correction, in accomplishing the surgical goal, right? So no longer do I have to worry about the frustrations or the troubleshooting of just getting in the metal, right? The metal goes in very undramatically, as it should be, so that the rest of the surgery can be done to accomplish the surgical goal for this patient. Again, the next case, another very fairly standard deformity, a T9 to pelvis that I did on this lady with degenerative scoliosis. This is her x-ray, and you can see on her CT, the sagittal on the left and the coronal on the right, a very extensive slip, right? And I remember sending this case to Dr. Lehman and asking, you know, with this bad of a slip, do you think I have to do an asymmetric PSO, or do you think I have to do even a VCR to release the spine to correct her within her parameters? And he said, you know, possibly. You have to always be prepared for those interventions, especially when you're dealing with something that can be hard to predict. Well, the thing is, the ability of the software to run through that predictive planning is one of those benefits. So you can see here in the X-Align, it pulls in the patient's own preoperative films. I've already delineated the femoral head, sacral slope, lumbar lordosis, and here I'm virtualizing, I'm inputting in, if I were to do 4 multi-level PCOs at this level of interest, and say I give myself an aggressive 8 degrees at each level, will this be enough to put her in imbalance? In balance. Will this be enough to avoid the morbidities of a 3-column osteotomy like a PSO or VCR? You can see with this, I can derotate the spine in anticipation of releasing the spine to correct her coronal deformity as well. This is the predicted pre-op, right? So the preoperative algorithm is telling me that she has 5 degrees of lumbar lordosis with a PI of 41. Here, with the multi-level PCOs, I get her back in match, right? So it's giving me about 37 degrees of lumbar lordosis, again, with a very low PI of about 41. So this was the predictive algorithm, and these were her standing films, right? So you can again see an exceptional amount of predictive overlap between what I can anticipate and what I can get away with, right? Again, it is an ideal scenario, but in this case, with a surgery like this, and everything is a bit of a mess with a really bad degen scoli, putting in the instrumentation was the least of my worries. And knowing that I had a good likelihood of being able to get away with just multi-level PCOs instead of a huge 3-column osteotomy allowed me to accomplish that plan. Now, my last open deformity case is a T4 to pelvis revision. So this was a gentleman who came in with an already existing construct. The thing is he was haloing his entire sacroiliac distal fixation. You can see here the CT scan showing complete haloing of the S1 screws as well as his single iliac screw. He was in a terrible amount of back pain because he was just pulling out the entirety of his prior construct. So here, the planning is going to give me the ability to put in 2 S2 AI screws. Now, for those of you who have put in S2 AI screws, and I put them in freehand, I put them in navigated, I put them in with robotic assistance here, let me show you what it takes to put in an S2 AI screw with navigated robotic assistance, right? The arm puts me into position, I drill, do 2 of my taps, I put down the screw, release the driver, send the arm to the second screw, repeat, and I'm done, right? Again, it's meant to be as undramatic as possible to help you accomplish what is, in his case, this is his primary surgical goal. The primary surgical goal is to give him back good sacropelvic fixation for his construct design. You can see here the design on the left, greatly opposed to the end product on the right, on coronal, and again, sagittally, the design on the left with good apposition to his end product on the right. And again, what I really want to show you is this postoperative CT showing those two S2AI screws completely avoiding that halo tract. Now, I mean, I don't know how good you are in putting in S2 screws. For me, I am not good enough, or I would be confident that I would be able to put in 2 screws, avoid that tract with just the freehand technique, or even with navigation alone. But again, this is a very niche case, but showing you the precision and accuracy of planning where you want your screws to go, and then the ability of the arm to help execute your plan with good reproducibility and accuracy. So again, he had a good outcome from this. Now, the second portion of this workshop, I do want to spend on minimally invasive deformity. So here, the ability of the spinal robotics platform to put screws and implants where we want opens up this new approach with new possibilities, because now, as Dr. Poulter mentioned earlier on in the general sessions, you can do these long segment transfascial constructs that are designed preoperatively. You can put in 4 rods minimally invasively. You can do multi-pelvic, robotically guided distal fixation, proximal MLSS screws, which are transvertebral screws meant to preserve the posterior junction and the posterior ligamentous complex to reduce PJK and PJF, and all of these new things that were either not possible before or exceptionally prohibitive before. And this is essentially that leading edge of innovation and disruption, and will be exceptionally controversial, but opens up the idea of possibilities that just weren't possible before. You can see here, one of the plans that we're going to go over, but just the ability to do surgery in new ways, potentially safer ways that would not have been possible for deformity surgery prior to robotics. This is a really favorite slide of mine, kind of showing and representing how spinal robotics, in my exceptional belief, can and will disrupt how we do spine surgery moving forward. So for the first case, a T10 to pelvis, right? A 68-year-old coming in with sagittal imbalance. You can see here a smaller segment surgery that essentially failed and subsided. This is my design for her. Again, in the software, I can put in 4 rods. I can put in 4 areas of pelvic fixation, especially since I'm doing it minimally invasively. I can do a more robust construct now that just wasn't possible before. These are the trajectories that I can anticipate to travel transfascially. I do a 4-to-1 OLIF, and then knowing that she has a very flexible sagittal deformity, I know that once I put her on the table, I can just lock her in. This is her prone, and this is that forest of towers. Because every single screw is placed minimally invasively, there are all these towers that just come up into view, which can be very, very daunting. But I'll say that passing these rods takes less than 10 minutes for all 4 rods, because again, everything lines up based off of that preoperative plan. You can see here the postoperative design and construct, 4 rods, 4 areas of pelvic fixation. And again, it's not just about a pretty x-ray, right? She had a great correction in all of her parameters. She had a great looking x-ray, but the whole point in trying to do this with robotics is to do this minimally invasively, because the benefits of this minimally invasive approach were realized for her. Intra-op, she had an EBL of 200 with no blood transfusions. She went straight from the OR to PACU to med-surg. No ICU stays, no fluid shifts, no waiting on all of the morbidities of a long surgery. She went home on post-op day 4, right? And again, for something as safe as that, being able to execute the surgical goals, I could not ask for anything better. The second case is a T12 to L4, a T9 to pelvis, right? So this is a gentleman who's 75, and 75 is just at the limit of probably a lot of deformity surgeons' cutoffs between someone who is just too old where the risks of a complication from open surgery start to really overtake any potential benefit that they may see. But he was exceptionally persistent. You know, he's a developer here. He's used to being exceptionally high functional. He wouldn't take no for an answer. I am easily bullied. And so I told him I would give it a shot and try to plan something that would be safe and robust and still accomplish correcting, you know, the surgical goals. So in the software plan, here it predicts his lumbar lordosis at 31 degrees with a PI of 55, right? So a mismatch of up to 25 degrees. With posterior column osteotomies at a conservative 6 degrees, it gives me 49. And then say I'm able to put in cages to give myself a little bit more. And then I reach 65 degrees of lordosis for his PI of 55, right? So this is pre-op and this is post-op, giving me an estimated about 35 degrees of correction, essentially virtually, right? So, you know, this is weeks before the surgery. There's no figuring out in the OR. I can play around with this and see if I can bring him back to something acceptable. This is my design, right? So again, I can do 4 rods. I can do 4 points of pelvic fixation. In this way, you see a variety of screws. There are transvertebral MLSS screws. There are cortical screws, juxtapedicular screws or standard screws. Each screw is placed with an intent, right? It is part of the larger design. And no longer are we just putting in your standard, you know, transpedicular screws just to get bony fixation. You can now put it with intent and with purpose so that it serves the entire design. These are, again, the 4 points of pelvic fixation. I promise it is not as complicated as it looks. Utilizing this is like learning how to use a PAX machine, right? If you can use a mouse, if you used a PAX machine before, learning how to use the software is exceptionally intuitive. Planning pelvic screws and S2 AI screws is no more difficult than planning any other standard pedicle screw. This is the output. So it's telling me, you know, my expected rod, where all the trajectories are going to go to make sure my incision is intuitive. And then on the 3-dimensional recon, I already know why I have to do the OLIF and lateral approach, because here you can see the lateral osteophytes. So if I had gone through this just purely posteriorly, there is no way in my hands I would have been able to mobilize the spine from just a posterior approach. So going from the lateral approach to break this up and release the spine was also helpful in being able to utilize the software planning to both predict and anticipate that. You can see here L3-4 and L2-3, and then loosening the spine more at L1-2 and T12-L1, doing the OLIFs and laterals at these levels. And then this is what it looks like posteriorly, right? So all, the majority of the screws being placed transfascial, the very little amount of blood that you can see in the field. You can see here again the forest of towers, which looks very daunting. But again, the towers are based on the preoperative plan of all the screws lining up in a planar fashion. Right? You can see the accuracy of the robotics platform. And you can also see here on the right-hand screen, the segmentation of each segment. I have already put in the cages, and this is based off of a preoperative supine CT. And the software has been able to detect my correction at those levels and still help me place my implants down my planned trajectories. This is the X-ray, which again can be very daunting. But what you see here, the purpose of this approach, the minimally invasive hybrid fashion, I'm only opening the spine where I want to do my posterior column osteotomies, only from T12-L1 to L1 to L4, just behind the cages to get that much more compression. Once I'm able to do that, this is the final construct. Again, a 4-rod, 4 pelvic fixation construct placed minimally invasively. The post-op CT shows, again, all the screws where they should be, right? So a variety of different types of screws, all serving the purpose within the design as a whole. And as difficult as a case as this would be, putting in the screws becomes the least of my worries. And I can focus on, one, his health during the case at 75, 76, and making sure I can get the correction from a minimally invasive standpoint, which is going to be more difficult than an open surgery. You can see the predictive on the left with good apposition to his outcome. I was able to get about 40 degrees of regional correction. And you can see here his standing films showing that correction and showing that improvement in sagittal alignment. But like I mentioned in the previous case, it's not just about getting a better x-ray. It's not just about subtracting all these spinal pelvic parameters and making sure that they're green. In this way, spinal robotics is allowing us to get a potentially better clinical outcome for appropriate patients. Because this patient, despite all that metal in his back, he had an intra-op blood loss of 300 with no blood transfusions whatsoever, no fluid shifts. Again, I'm at an academic center, right? So we do deformity surgery, but by no means is it a boutique deformity only hospital. I get rotating anesthesiologists, and so they're familiar with spine surgery, but they're not subspecialized in, you know, these high risk deformity surgeries. Doing this minimally invasively, I was able to keep the blood loss low so that the anesthesiologist had a much better time keeping this 76-year-old safe. He went here right to med-surg, walked on the first day after surgery. He was sitting and walking, went home on the 5th day. So again, and you know, he sent me a really nice email, you know, really complimentary to how good his outcome was. And again, with as good of an outcome as this, I couldn't ask for better than this. Now, the last case, again, that I'll go over for minimally invasive deformity in L2 to S1 with an MIS T10 to pelvis, 73-year-old, right? So 73-year-old female with morbidity. She's already had prior DeanSys stabilization system. You can see her spinal cord stimulator already turned down by a lot of surgeons because of her morbidities and just because of her age. And so she's coming to me as sort of that last resort and seeing if there's something that can be done to give her back that quality of life. I input in her parameters into the software planning, into Exeline. I see that it's telling me she has a lordosis of 41 on supine CT compared to a PI of 70 degrees, right? A mismatch of almost 30. And I say, well, if I do a multi-level O-lift and I can really get a release based off of these O-lifts, can I get her back into a match, right? Can I give her the safest surgery that I can while still accomplishing those surgical goals? Because of her morbidities, and she was, you know, as you can see from her x-rays, she was a bigger lady. I wanted to give her good pelvic fixation in a rigid construct because I didn't want anything to pull out. I didn't want anything to fracture. In the older, you know, when you're doing things minimally invasively prior to robotics, all you could do was probably 2 pelvic fixation points and 2 rods, because that's the maximum amount that you could do to put things transfascially. With robotics and with software planning, I can do something more. I can do something much more robust, tailored to this patient who was on the larger side. So as you can see here, a minimally invasive approach at L2-3 and L4-S1. I did 4-to-1 first and then went up to 2-3. You can see here the small incisions, trying to minimize the morbidities associated with someone who's elderly at 73, someone who does have a higher BMI, but does need surgical care. This is the Forest of Towers, again, done through a transfascial approach. There is very little blood loss here, but as daunting as all these towers are in the surgical field, placement of that rod is exceptionally intuitive because I've already lined up everything. I've already put in the work to design this construct so that all 4 rods would pass less than 10 minutes time. This is what her final plan was compared, or her final construct compared to her final plan. Again, very good predictability of what I can expect and what the robotic arm is able to give me based off of the placement of where I want my screws to go. And again, it's not limited, obviously, to these types of, you know, diverse, potentially controversial screws. I'm putting in transvertebral, multi-level stabilization screws to preserve the posterior ligamentous complex. I'm putting in cortical screws. I'm putting in S2AI screws. You can put the screws wherever you want, right? And the screws will go based off of what you put in your plan and where you tell your robotic arm to go. This is the pre-op and post-op, right? So again, I got her back 5.2. Could I have gotten more with open surgery? I probably could have, right? This is, you know, this is not a home run, but I definitely got on the scoreboard. But the thing is here for her, tailored to her age and her morbidities, the minimally invasive approach, very little blood loss during the surgery. Went post-op right to med-surg, home on the 5th day. And again, with her, a very nice note saying how much her life has changed, right? And this, again, just like I've been saying with the last 3 minimally invasive deformity cases, nothing, I just couldn't ask for better than this. And so this is the leading edge. When it comes to spinal robotics, there are so many disruptive fields that we're talking about within degen and deformity and single position surgery. But for deformity, this is really a leading edge with new possibilities and new ways to do things. And when it comes to MIS surgery, not every patient is going to be appropriate, right? As we've seen with the MIS-DEF criteria, there are patients where open surgery is going to be much more appropriate to accomplish surgical goals. But what we're seeing now is an ability, a capability to do things that we just couldn't do before. And so I'll wrap this up so that we do have a few minutes for any potential questions that you do have. This is a favorite slide of mine that I have in a lot of my presentations, but just old ways won't open new doors. And in this way, we're focusing on these old ways of how to put in pedicle screws. Are you putting it in with navigation? Are you doing fluoro assist? Are you doing the freehand technique because you understand the anatomy exceptionally well? Do you do robot assist? But all this focus on the pedicle screw is such a very narrow tunnel vision of what the bigger picture is. And really the bigger picture is how spine surgery is changing with the addition of spinal robotics, predictive algorithms, software planning, so that we can think of spine surgery in an entirely different way. And in doing so, we can potentially and hopefully, as the goal, get better outcomes, better patient care, and minimize all the morbidities that may be associated with intervening in the spine. And in this way, the use of the